NHS is not working now because people are impatient. They don't want to queue. They don't see the fact that it's now being impacted by people living long. So their population of senior citizens is going up. You don't want to be in an accident in certain areas because you're going to be in trouble. I mean, we had an ombud that said, don't take my people to Rahima Musa Hospital. They'd rather die in the street. You don't see your own father and mother as part of you. You've accepted the fact that they are stuck
in the township.
In a public healthcare system you will not be seen dead in. If you're African and you're competent and you're ethical, you are fucked.
With a capital F.
Yeah, with a capital F.
Yes.
Because whites don't want you and your fellow blacks don't want you either.
Wow.
Because the common refrain goes, that one.
King David Studio podcast.
I have in the studio Kgosi Letlape, who's a medical doctor of many, many years. And interesting, before we started talking, where he was reminiscing about his time at university. But today we called him for a very different reason. It has to do with the NHI. And most of us don't quite know exactly what it is. We know it's happening. We know it has to do with the health insurance. But we don't quite understand the intricacies that go in that. And today we're going to have some form of a master class, but with someone that in the interviews I've seen, he doesn't quite agree with a lot of the aspects that come with it. He'll explain all of this himself. Rewe, I hope you're well.
I'm well, and I'd like to thank you for inviting me.
Thank you very much. I've seen and read and tried to understand what NHI is. And I consider it simple on paper, but it seems like there's a lot that goes on in it. There's a lot that people may not quite understand. Am I correct to say that?
Yes, you are correct to say that.
Okay.
And unfortunately, the poor understanding is not just amongst the general population. Even some of my colleagues and other healthcare professionals don't really understand what the dynamics are.
And what do you think is the impact of this lack of understanding by both professionals and everyday people?
The impact will be lack of awareness of where we're being taken to. The impact will be not being able to ask the right questions about what is being put on the table. And you're going to end up with a situation where a few years down the line, we're worse off than we were before. And people will ask, but we were consulted. What did we not see
or understand?
Do you remember prior to the Zondo Commission, there'd always been these issues about corruption here, corruption here, corruption here. But there was something that was expressed in the media about the fact that we as South Africans were not connecting the dots. Do you remember?
I remember well.
When we connected the dots, the concept of state capture was put on the table. And we are still beginning to understand how the state is captured. So maybe even with NHI, we need to begin to connect the dots.
What is NHI?
Well, NHI, as is expressed now, it stands for National Health Insurance.
It's a fund.
And it's a fund, basically. I've been engaged with the officials in the ANC, in the party, and in the department from as early as 2007 around the subject. We've been engaged in trying to create a better healthcare system ever since the dawn of democracy. In 1995, the first Minister of Health, Nkosi Dlamini-Zuma, put a plan on the table that was supposed to be a building block for a national health system. I don't know whether you remember, maybe you're too young.
I know.
We're talking about social health inquiry.
I'm glad you think I'm too young. That means I look young, but I know a lot of
social health inquiry. And there was an inquiry that was co-chaired by Jonathan Bloomberg who ended up being one of the seniors in Discovery,
Yeah.
and Olive Shesana,
Oh.
who was the first Director General of Health in the New South Africa. And part of what was in that plan was about ensuring that every citizen is assigned to a GP.
Mm-hmm.
And all GPs would be contracted by the system.
Makes sense on paper.
So we would access the healthcare system through our general practitioners, just like it's done in the UK. Unfortunately, that plan was supported largely by black doctor groups. It was not supported by whites. It was not supported by the Medical Association of South Africa at the time. But more importantly, she couldn't get the support of Madiba's cabinet to put it through.
What was holding it back at the time? Because it sounds like a good idea.
You see vested interest. You know, when you have a system that doesn't work, it might not work, but somebody's making money out of it.
True. There's always a winner in any disaster.
That make money out of any system will resist that system being changed.
Of course.
Because they're benefiting from it. So the many things that the minister was putting on the table was about access to doctors, access to professional care, access to nurses, access to pharmaceutical products, bringing drug prices down, etc., etc.
Yeah.
But when you come and you're trying to configure a system to benefit all citizens, and you're coming into a place where some communities were benefiting, those that were benefiting are going to be anti what you propose. That's why it was not surprising that the Medical Association of South Africa, which is basically the home for white doctors, opposed these changes. SMDP, which is one of the black doctor formations, supported this project because things would get better for us and the majority of our people that we served. And there was a fear by those that had good services that things would get worse for them.
But how? If the benefit, one, is for everyone, two, they'll be getting more clients and they'll be funded by government in that context, how would it get worse? Or it's just the fear of the unknown?
Because you see, when you're saying benefit for everyone, you are bringing those without benefits to benefit. But if you are already benefiting, the scheme is not, you might perceive as a threat to what you already have. If you already have, you don't want anybody in.
Of course.
And just think about that, because at the end we'll come to the situation of today where the people on medical aid, they don't want to hear anything about NHI because they have something. And they want others kept out. Or at best, they fear losing what they already have. You're trying to bring everybody to have what I already have. So I fear losing it, or it being diluted, or its quality not being good. You know, the old story of when blacks move into a neighborhood, the value of the properties go down. That kind of thing. Those who have will do everything to protect what they have. And it's got nothing to do with color. It's about human nature.
However, NHI is about bringing everybody on board, isn't it?
Well, that's what it is supposed to do.
Yeah.
Okay. Now, I will be here and I'll go back. But you see, by simple definition, if it's national, it has to be for everybody.
True.
You can't call it national if it's going to be for everybody somewhere down the line. Now it's going to cover a certain sector of a community. Then it's not national. Then you need to explain it so that it's understandable, so that anybody can connect the dots to say, national health, this is where it is taking us. The fund is a first step. But you got to do the whole roadmap for everybody so that everybody understands how the fund is taking us to the promised land.
But so far, the understanding is not crisp.
But that's the point. Why are we not demanding that it be crisp? Why are we accepting something that is not crisp? Is it because we dull, or we don't understand, or we can't connect the dots?
Or maybe we trust the driver to take us to the right place.
No. Our decision making is driven by fear.
And us as the majority, the
Yes,
population.
those who have are fearful they're going to lose. Those who don't have are excited by the promise of having.
Mhm.
Even if it's not practical,
Or clear.
even if you don't see it being done. Nobody is clarifying the fact that, oh, we're bringing you in, but this one's feels, but we already have.
Mm.
If we already have, what are you bringing us into? So you'll hear the common refrain: leave us alone. Fix public health care first.
That is a common statement.
That's a common statement.
Yeah.
And that's because of that fear. Because nobody is explaining the fact that the challenges that we have is because of separateness.
Mhm. Explain that, please.
Okay. Many experts have said over the years, you go to the 2000 World Health Report from the WHO and the World Bank, say South Africans are spending a hell of a lot of money on health.
Mm.
And they are getting very little out of it. They're spending far more than other countries that are spending less of their GDPs for better health services, for better health outcomes, and for better lifespans.
Mhm.
So our ab initio problem is not money. Our ab initio problem is the separate pots. That's the first fundamental problem.
Yeah. We are separate.
It's separateness.
Yeah. Okay.
Then the second issue is ineffective utilization of the resources.
Yeah.
And you can unpack the ineffective utilization. And one of the key ingredients of ineffective utilization is non-essential third parties coming in, and they basically run the show.
For example?
Administrators.
Okay. It's not the healthcare, it's
Tenderpreneurs in the public healthcare system.
yeah.
You can have a well-functioning, efficient, affordable system without these third parties that add no value.
Are you saying run solely by government, where there's no external resources?
I'm not even talking run by government.
Uh,
I'm talking about structured properly.
okay.
It don't matter who runs it,
Yeah.
but you're running it for the benefit of the members. You're not running it for the benefit of the shareholders, of the runners.
Of course. I got you.
Did you understand what I'm saying?
Yes. It's at its core, it goes back even to the Freedom Charter. It's about the people in the end. It's not about those who benefit from it.
Or what I'm talking about, something that people might relate to. You have COVID, you create an emergency fund, and you have people that know nothing about healthcare that are coming up with companies. They can't tell a syringe from a gauze swab.
Or a mask.
And they are given a contract to deliver masks or to deliver X for us. And they make millions out of that without delivering anything. That's what I mean about a system where you have third parties that add no value being the ones that run the system.
Have we been able, and I'm asking a general question, have we been able to get that right? It remove health from it for 1 second.
Oh, yes. There's a period when that thing was right.
Mm.
But you got to go back to pre-94 to see how they got it right.
Mm.
I'll take you back to where we should start from. There was a First World War. And people started talking up post the First World War about universal health coverage. That's in the 1920s in South Africa.
Mm.
There was a Second World War. And there was a new reverberation about healthcare for all. Post 1948.
So these conversations
in
were even
1948, healthcare was haphazard, not organized, and not accessible for most people. What happens in 1948 in South Africa?
Remind me, it's apartheid.
The National Party wins the election.
Yes, in the beginning of a new era.
They come into power.
Yeah.
What happens in the UK post 1948? They are poor. Healthcare is in shambles. There's a minister of health that comes in and he says, we're going to build a national health system. They couldn't afford it. They were poor. Britain was in ruins. That's when they introduced the national health system. It was opposed by doctors. It was opposed by the British Medical Association and all healthcare professionals. He got political support, was resolute, and was able to build a national health system. Contrasted to South Africa, 1994. We had our own visionary to deliver a national health called Nkosazana Dlamini Zuma. The difference between her and the minister of the UK post the Second World War is that minister got cabinet support. Nkosazana Dlamini Zuma failed to get the cabinet support of her own party.
Let's go to UK and spend a minute with UK. 1 second. Did it work?
Oh, yes. Oh, yes. You see, sometimes you become a victim of your own success. Okay, when you go to the UK, you don't hear them talk about stock outs for basic drugs. You don't hear them talk about children that need immunization that are not being immunized. You don't hear them talk about a person that needed emergency care that was denied and died in transition. You don't hear them talk about patients that starve in hospital. You remember COVID, with a famous personality who was starved in Tembisa Hospital?
True, yeah.
Okay, they live a long life.
Yeah.
So what is happening in the UK is that they are now dealing with the successes of having improved access, increasing lifespans. So they have an aging population that lives too long, that is now having incredible demands on the health system. Same problem in Scandinavian countries. So what you then highlight is the fact that, there's a long waiting list for cataract surgery, there's a long waiting list for hips, etc.
Old age problem.
Yes, but you're not talking about a 13-year-old that dies unnecessarily.
True.
Children that are dying of starvation in the Eastern Cape. So you then say NHS is not working now because people are impatient. They don't want to queue. They don't see the fact that it's now being impacted by people living long. So their population of senior citizens is going up. And the demands on the healthcare system become quite high. So you now have people that live to 80 and the hips are gone. They're waiting for hip transplants. They're waiting for knee transplants. They're waiting for cataracts. That's because the system has worked. We die at 40, so our system won't have that problem.
No.
Because we die at 40. What was our lifespan at the height of the HIV pandemic when we were denying people ARVs?
Yeah, that era.
So understand that the NHS has been successful, but it's now has to deal with how do you deal with an aging population?
Yeah.
So you have problems of a different kind. You've given them a good life. You've given them good quality life. They're living to a ripe old age. You've created a new problem.
But it's still a solvable problem.
It's still a solvable problem.
Yeah.
Some decisions might be difficult decisions that need to be made. But it's a nice problem to have. I've just come from Indonesia where they were talking about racism amongst health regulators. And I said to them, racism is a nice problem to have.
Tell me why you say that.
We're still backward. Yes. Because our problem is tribalism. Our problem is self-hate. Now, racism is when you hate others. Self-hate is when you hate yourself.
And your people.
So when you begin to love yourself and you now have to deal with other groups and you're dealing into tribalism, that's a better problem to have than self-hate.
Not everyone will agree with you, but I hear you.
So that's what I mean. It's a nice problem to have.
Yeah.
What nobody talks about is the fact that if you need emergency heart surgery, you have access to it. If you are in an accident in the UK, do you have medical aid? Wait for an ambulance that will take you to Barra. You have medical aid, will lift you by helicopter to Millpark.
They'll take you to the nearest hospital.
Everybody gets picked up. Everybody gets taken to the hospital.
Do they get the care they deserve?
Oh, yes.
Yeah.
Oh, yes. There's no Brit that says, I hope I don't get an accident when I'm in that town. because they know they have a system that provides proper emergency care. You don't want to be in an accident in certain areas because you're going to be in trouble. I mean, we had an ombudsman that said, don't take my people to Rahima Musa Hospital. They'd rather die in the street. So whatever challenges they have in the UK, they don't have those problems of saying, Boris Johnson say, don't take me to a public health hospital. When he had COVID, he went to a public hospital where the ordinary people go. So we have this thing where we don't want to compare apples with apples. They have no floor beds. They have no overflows. They don't have patients that don't have food in the hospital. And we come and say, oh, look at the NHS. If we had it, 99% of the complaints we have would be gone.
How did they get it right?
That's the point that I want to come to. They were poor when they decided on a national health system, but it became common for everyone. It was the same for the prime minister, the same for the cabinet minister, the same for the businessman. It was a system for all citizens. Eventually, the doctors came around, they contracted with the GPs, and the way you access the healthcare system is that you have a GP that you've chosen. That's your GP. That's your guide, and that's your entry point into the healthcare system. And everybody, even the Queen, had a GP.
Wow.
Common entry points for everybody. They didn't have community health workers for immigrants and staff nurses for other immigrants, professional nurse for others, and entry points for the low-class Britons is a GP, and for the high-class Britons is a specialist. The common entry points. Equitable for all citizens. That's what a national system looks like. It's the same for everybody, and the head of state leads by example on going to that system. I mean, President Ramaphosa, I heard him quote the fact that one prime minister of Sweden said to him, the difference in our system is I'm in hospital now because I need to be in hospital. My neighbor is an ordinary miner. I'm not in a 5-star hospital anywhere where they can't see me. I'm accessing the same hospital as the people.
He told that story?
Yes.
What was the point of it? Because it works against his reality.
No, but the point is it was to motivate why we need national health.
Okay.
But is this national health?
Let's go back to the history lesson.
So the history lesson is that the UK comes out of 1948 and they build a national health system that we criticize now out of ruins that outperforms our system by logs. Okay. And just because people are anti-unity, they will try and trash the national health system in the UK. You go to Cuba, pound for pound, the best healthcare system in the world.
True.
Given the resources they put in there. You go to Scandinavia, they have national health system. Everybody is equal. We all enter through the same entry points. That's what a national health system is about. That's what it should be about. They build it from then on to what they have right now. But guess what happens in South Africa? The nationalists come in.
1948.
1948.
Yeah.
They come in with their segregationist policy. But by 1967, that's 19 years later, they give the world its first heart transplant in a public hospital.
Yes, Chris Barnett.
Public hospital built by the Nationalist Party for whites. So you go back in history, white public health was the best healthcare system the planet has ever seen.
We've been there.
But it was segregated. It was white.
Yeah.
And for other groups, the health systems were not as great as the health systems for the whites.
How did they get it right?
By just resourcing it, building it, equipping it, running it ethically, buying for the whole nation, collective buying. Nobody is going to mess you around with prices. The technology is owned by the system. Chris Barnard didn't have to go and rent out a heart-lung machine from the private sector. And actually, at the time, the private sector may have wanted to rent out from him.
Yes.
They built a system where when you were sick in private, you went into public to get the proper investigations, proper diagnosis, and proper treatment.
Some would say it's still the same today. That last statement you made, you want the best health care, you go to these medical schools. Steve Biko in Pretoria and Bara in Soweto.
Yes and no.
Okay.
Yes and no. Before, you didn't go to a medical school. You just went into the public healthcare system.
Okay.
So they had proper referral patterns where the hospital will be equipped to deal with what it needs to deal with, and what it needs to refer up, it would refer up.
Okay.
So when you get up, you never got people clogged up there where someone with flu has gone to Steve Biko instead of going to the clinic.
It's wrong place. Yeah.
So all those things matter in building up a functional health system. And the entry points are the same for everybody. If you get a heart attack, you'll end up in an emergency facility, and you'll fast track yourself into tertiary care, tertiary and quaternary care.
Yeah.
But if you have bowel loss, you don't go to
go to clinic
because you know the professor is your friend. No. You start at the common entry point.
Yeah.
So it's a system that was performing.
But it seems like it took us very little time to change it. Because
no, it took quite a long time.
Okay.
It took quite long because they built a resilient system. So even breaking it down has taken quite some time.
Yeah.
It wasn't broken overnight.
Is it completely gone now?
No, there are still, as you say, there are pockets of excellence. I mean,
Okay.
I've had a personal issue that I got treatment for, and I chose to go to Steve Biko Academic.
Because you even knew that you would get...
I know the people, but before, you didn't have to know the people. It was available to all white South Africans.
Yes. Yeah.
Okay, so 48, 67. Guess what? The Medical Schemes Act was first passed in 1967.
Whoa. As old as that system.
Oh, yes. It was, but Medical Aid Schemes Act was not done to be the place where people get healthcare. It was done to organize primary healthcare that was occurring in they wanted to control what was happening in industry, because some of the employers in Johannesburg started benefit schemes for their employees.
Okay.
Medical benefit, medical aid, and the nurse wanted to control it, so they came up with an act that would govern how it is done. And the principles of the act was that, there'll be funds that will be run in accordance with the Medical Schemes Act. There'll be a judge that'll head a commission which will negotiate tariffs with providers.
Wow.
So the doctors, the associations had to go there, present and say, we want to charge X for a consultation, Y for taking out a tooth, Z for an appendix. The hospitals were there, the pharmacists were there, all healthcare professionals. But there was a tribunal that was chaired by a judge.
Similar to electricity.
That agreed on the tariffs.
Because if electricity is agreed, whether we agree with them or not.
But that was for minor ailments when it was started. No white person had medical aid for major illness. They had a white public healthcare system. This was just the inconvenience of going to queue at a public hospital. You can just go see a GP with your benefit card, and then go back to work. But when you were really sick, you went into public health. Do you know a person called Tony Factor?
No. Who's Tony Factor?
So I guess you didn't grow up in Johannesburg.
I grew up in Pretoria.
Tony Factor was a Jewish businessman that owned half of downtown Johannesburg.
Whoa.
Was owned by Tony Factor. When Tony Factor had his heart attack, guess where he got his care?
Don't tell me it was a public hospital.
Johannesburg Hospital.
General.
It was still called General. White public hospital.
Joburg Gen.
That's where he went for his bypass surgery.
What?
When I grew up, my children are born in the 80s. Late, mid 80s, early 90s. All my kids were born in a private clinic. My white contemporaries were laughing at me because Bara was deteriorating. Things were bad. We had to go private. At that time, in the 80s,
Why are they
the
laughing
best
at you?
delivery units
Yeah.
were still in white public health. All their kids were born
In public.
in white public hospitals.
Wow.
That's how robust that system was. That's how well built it was. When I trained for my specialization, which is between 84 and 88, patients in the private sector would be referred into the public institution for serious illnesses and serious investigations. The capability lay inside the public sector. We have something called a fluorescent angiogram, which is where you inject the dye to see the circulation in the retina of the eye. It was not available for a long time in the private sector. So we used to ship patients in for electrophysiological tests, for angiograms, and other things that could only be done in the public sector. If we had children that had ocular tumors, retinoblastomas, the best treatment center was in the Joburg Giant, Hillbrow Hospital.
Incredible.
That was the radiation center for the country. Made isotopes made in South Africa to treat cancers, exported from South Africa. So people need to understand that they created that between 48. By 67, it could do that. By the 80s, it was still resilient. Let me tell you a story, what happens. In 1984, I'm a senior house officer. I'm in a cardiothoracic department at Bara. Now, I can't go to the White Hospital. I can't touch white patients. I can't get into the White Hospital. It's 1984.
The heart of apartheid.
I'm in a cardiothoracic unit. Post 76, 61, 60, Sharpeville, it was problematic, but they still felt they could contain it. Come 76, they make a strategic decision to no longer invest in the public healthcare system.
Wow.
To privatize it and build a private healthcare system. So what you see today is not a default situation. It was proper planning for the pursuit of separateness.
Wow.
Under commercial guidelines, not determined by the color of your skin, but the color of your money.
Yeah.
And they did it, they planned for it. So from then, they stopped building public hospitals. They started a build program for private hospitals. They licensed private hospitals. They ensured that they get funding. They then use the Medical Schemes Act to create privatized care for whites. They look at it, they use it as a template. Then suddenly, if you're white and employed, you have to be on medical aid.
That's the birth of Bonitas.
No, that comes later.
Okay.
Then suddenly, this emerges. By law, only white people could belong to a medical aid. Wow. Something that you guys don't know.
No,
medical aid was meant for white. Medical aid was then seen as a mechanism to preserve white privilege.
Wow.
And that's how medical aids are formed. Then it's compulsory for employers to put their people on medical aid. I come in to work as a doctor. There's a public service medical aid. But it's only for whites. I can't join it. I'm a public servant. I can't join it. So there was pressure on that basis to say even educated blacks need privileges. Under pressure. That's how Bonitas is born.
To help the darky version.
But a Bonitas becomes a medical aid for Africans. Even when they relent and allow affluent Africans to have medical aid, they still have their segregationist ideas.
Yeah.
So they create a medical aid for Africans, they create a medical aid for coloreds, and they create a medical aid for Indians. separate. Pro sano, sanitas, and bonitas.
Jeez.
That's the history of where medical aids come from.
Yeah.
But basically, medical aids were meant as a refuge for white privilege. So there was systemic underfunding of the public healthcare system. They took a strategic decision to build the private healthcare system on the backs of medical aid. It's an act of parliament, and that's what it was used for.
Let's pause 1 second and analyze the psychology of that decision. To say they are uprising, we can see, and we don't want to fund their resources, Botaki, anymore. What was the thinking behind that? Because you need a healthy workforce as well. Because the country was built on
the thinking was basically these people had academics that thought out these things. The Broederbond was not leaving anything to fault. It got their best brains to think about these issues.
Okay.
So what would happen is that they had this vision of they are committed to apartheid for as long as they exist on this planet.
Mm-hmm.
Nobody's going to accept them anywhere. They don't want to go anywhere. They cannot reproduce the white lifestyle they have here anywhere in the world.
Yeah.
So they committed to stay here and they want to continue with that lifestyle. So what do? They privatize public health. They create these funds to build that up. They now stop strategically funding public health, whether it's for blacks or it's for whites, and they're building a white healthcare system. They issue licenses. They are no longer supporting the public healthcare system. So, in 1984, there's a Professor Kingsley who runs the department in Johannesburg Hospital. He's the head of cardiothoracics at Wits. He runs the department. There's a guy called Manuel Antunes who used to run cardiothoracics in Mozambique and post Frelimo 76, 73. They couldn't go to Portugal. Some of them went to Portugal. He and his other colleagues chose to come to South Africa. Brilliant surgeon. He heads the cardiothoracic department at Bara.
Wow.
Then because of this chronic underfunding, it's now impacting on the wide public healthcare system. So the cardiothoracic department is beginning to be challenged, about research, taking scholars to conferences, equipment, new equipment, modernization, and those things are not occurring. So the private sector is growing because of this decision. So there's a guy called Barney Hewitz, owns a group called Clinic Holdings at the time.
Okay.
And one part of it is Mill Park Hospital. Barney Hewitz equips Mill Park Hospital cardiothoracic unit to the levels of any cardiothoracic unit anywhere in the world.
Yeah.
And goes to Kingsley and says, hey, all the things that you want, they're here. Overnight, one day, Kingsley resigns, takes all his senior staff, and they're going to start the unit.
Wow.
At Mill Park because of the underfunding of the public healthcare system. So it's beginning to struggle. It can't do what it's supposed to do.
Yeah.
So Kingsley moves with the whole team out there. So suddenly, whites don't have access
to
cardiothoracic services in Johannesburg.
Surely that was working against the bigger plan.
But guess what happened?
Whites looking after their own whites.
But guess what happened? No. They've taken a strategic decision that will take care of each other in the private sector. They were privatizing white public health.
Privatizing apartheid.
Yes. You're keeping apartheid, but you're taking it private.
You're taking it to the money.
Yes.
Yeah.
And remember, this money is collected based on an act of parliament.
True.
It's not volitional money. It's not money that you choose to take your kids to private school with or have private security.
No.
There's no act of parliament for that. This one, there's an act of parliament. You remove that act of parliament, that this private system that we have today collapses tomorrow. It collapses tomorrow. And that's why they are concerned about national health. But just to tell you what happens next.
Yeah.
Antunes gets promoted
to
go and become a head of cardiothoracics at Johannesburg Hospital.
In the
The
public
current Charlotte McLean. No, he's in public, but he was the boss at Bara. Kingsley was the boss at the White Hospital.
Yeah.
So Kingsley's team walked out to go private. And the team at Bara is taken to go to the White Hospital. Then overnight, we black people have no access to open heart surgery. Before then, there was a dedicated theater at Bara that worked every day on cardiothoracics only.
Yeah.
Suddenly, there was no people to serve in there. People had to be prepared, wait for a slot if they were dying, be shipped out to Bara, to Johannesburg Hospital for an operation, and be weeks back to Bara for care because they can't stay in a white hospital.
Sure.
So I just want people to understand that the things that you see today are not default situations. There are things that were planned for, that were thought about. And so the new government was given a poison chalice, which was underfunded, which was crumbling, and there was no budget to keep up the facilities, no budget for CAPEX, no budget for human resources, no budget for consumables.
And as you say, it was deliberately destroyed for it to get to that point.
And then you add to that nepotism and corruption.
Of course.
Gee.
Wow.
And now suddenly, everybody that runs comes into this protected system where white privilege has been privatized, and all of us are on medical aid. In parliament, they are on PARMED. So all the privileged blacks that are in government, with all the government employees, are on medical aid. So suddenly you find yourself in a situation where we are now part of white privilege that has been privatized through the Medical Schemes Act. And that has been prepared for. So we've built this private system because of a fear that the blacks are coming.
Sure.
Now, even those of us that are in government fear poor blacks. So we're on that side of the railway, on medical aid, and we now have the temerity to say, fix the public healthcare system, leave our medical aids alone. When you understand where this thing comes from, you understand that this is political machinations. But blacks who are in power subscribe to it because we hate our own. How often have you had? I've had to deal with people that say to me, my father is not on medical aid. Things are bad at Bara. You are connected, Kgosi. Can you help? Can you help? Can you imagine? Liberated, educated. You don't see your own father and mother as part of you. You've accepted the fact that they are stuck
in the township.
In a public healthcare system you will not be seen dead in, and you're begging contacts to help your mom there. What does it say about us? When I talk about self-hate. But that's what self-hate, how it expresses itself.
But where are we now? Because for me, healthcare system is not a complicated concept. It's about the sick and having access to medical care in a country that can afford to look after everyone. That is at its core what a national health insurance speak of. It speaks words that are used when they describe it as universal health care and so forth. Is it as universal as it looks on paper?
Remember, what I want people to understand is the fact that our primary problem is separateness. So I was deliberate in trying to give you the history of this separateness. Is not a default. It's a design. It's something thoroughly thought out. And cultured blacks have been cultivated to be the ones that protect the new separateness.
Yeah.
Whatever language you're going to use, we are the ones. Okay. And when you go into medical aid, they created it to give exactly what they had. Do you know what was the policy of medical aid?
Okay. Take us back.
Medical aid policy and law initially was that everybody gets covered that's in medical aid. all of them get the care that they need. The providers, payment is guaranteed to them on proviso that they are prepared to be paid the rates that have been negotiated and agreed upon.
Because everyone is happy.
Everyone is happy.
Yeah.
And providers had a choice. And you know what was the term? If you accept the medical aid tariffs, you were contracted in.
By the system.
The term used was you are contracted in. So anybody that has a medical aid can come and see you. You can't ask them for an extra cent. You've got to give them all the care that they need.
Isn't it the same now?
No, it's not the same. It's not the same. You get into hospital now, you don't know what you covered for.
Oh, yes.
Or they tell you, we
course.
cover the front tooth, not the back tooth.
Oh,
You got a shortfall here. These drugs can't be paid for.
You run out of
that
money.
Have paid for, levy, you've run out of money. None of those things. It was constructed on the basis of universal health coverage, no payment at the point of service, care guaranteed, and payment guaranteed to providers.
Isn't that the language of the National Health Insurance?
No. They might give you whatever flowery language that they want to give you. But the point is, these were the principles. The last minute apartheid minister of health, before they left, they chucked all those principles out.
Wow.
Payment was not guaranteed. Care was not guaranteed. You could come up with different benefit structures.
In law? Was that in law?
Yes.
Yeah.
They made it lawful. And administrators can come up with core payments. And they can come up with exclusions. None of that was there. So the last Minister of Health, Rina Venter, amended the medical schemes to make it like that. So it became a third-party paradise. Before, initially, administration was internal inside the medical scheme.
You sorted out.
Yes.
Yeah.
If you're a medical scheme, you think you fit, you must be able to administer the business that you think you can run. Now they've been allowed to run businesses they can't run.
So the
and
cost
running
of
the business, it's outsourced to what they call administrators.
Yes.
And the only people that make money are the administrators.
Who foots the bill for this system you've just described now?
The members.
The members.
The members.
Yeah.
But remember, when now your money doesn't go to your care or to pay for providers, but the
guy who coordinated
the administrator,
this.
the guy who even if they disappeared, they add no value.
The game will
eventually
continue.
To care. You're not looking for administration. You're looking for care. So what you're looking for is providers. What you're looking for is a statutory mechanism of someone who just will be paid cost recovery to facilitate that relationship.
Yeah.
No, here they're making money. There were limits to admin expenses. At some point, it was no more than 2%. Then they rationalized and they increased it a little bit. But now they take up to 20% as admin fees. That's lost money for no value add. You know why they need that much money?
Yeah.
If I cover your left ear in summer and your right ear in winter, I need a complex system to manage that.
Yes.
If I just gave you care, say, what's your problem? Go to the healthcare professional, and the healthcare professional provides the care. As long as it's ethical, it's according to the rules, and the professions have agreed that's appropriate treatment, that's indicated, we pay for it. That's how medical aids were constructed. But what you have now, it's a haven for connected people. And guess what happens? The money was made by administration. So I saw it with my own eyes. Once they come in, the influential black people that are politically connected were now given shares in administrators, etc., etc. So right now, there's vested interest in administration of healthcare. And remember, what we are administering is diminished healthcare to members. That's why you need a complex system.
Sure.
So basically, that's where we are. That's why people will say, we don't support this because food is going to be taken off the table. They are fleecing the public. Whether you are a medical aid member or an ordinary member of the public. On one side, we're being fleeced by administration and unnecessary costs. On the other side, we're being fleeced by political cronyism, tender systems, and corruption. So there's rot everywhere. There's challenges both sides.
Which side do you choose to fix if you had to choose a side to fix?
You fix South Africa. And
Okay.
both are in South Africa. So you fix both of them simultaneously.
Okay.
Now, given the problems that we have, you tell me, how is the third fund going to solve all these problems that we have? Because our problem is not money. Our problem is stealing it. Our problem is taking it for use that is not needed, that is not appropriate, where there's duplication. I mean, you go to the UK, they don't have 15 administration systems running healthcare in that country. It's one system that collects information for better planning. Do you know how many billions you save if you implement that concept? Do you know how much money we've spent on admin systems, health systems at provincial level, at national level, and we got nothing to show for it? Nothing to show for it. So what you should ask yourself is, what is wrong with our system? So what is being proposed, is it going to fix the ills in our system, or is it going to bring us new problems?
You have come out to say it's not going to fix it. And I keep going back to the core of NHI. It gives the impression that it will. It says everyone together, one system, one universal fund. Yes. Isn't that a solution?
Just in terms of words, that may sound like a solution. Okay. Now, what I've painted a picture of is that you have two systems in South Africa.
True.
A public system and a privatized system based on medical aid. Yeah. Those are the two systems that we have. And you are suggesting that, we got so many problems. So the way we're going to sort them out is by creating a third tier called a National Health Insurance Fund. Now, when you create this National Health Insurance Fund, it's an act of parliament. You have a Medical Schemes Act, it's an act of parliament.
Still exists?
Still exists.
Yeah.
You have the way we're funding public health now, still exists. So you just added a third. Okay. Now, you explain to me. Once you create an NHI, you now have two financing systems for private health. Okay. What are you going to do to compel the medical aids to come into NHI? In which country? Under our constitution, there's a law
that protects this.
If you don't repeal this, you can't make this work.
But can they exist together?
No, they can't. They can't. And when you look at it, you see the confusion. Where they say, what we cover, medical aids can't cover. Now, you have got schizophrenic parliament that says, we're going to have an act here. And what this act of ours covers, this other act of ours can't cover. How do you explain that to a judge when those that are this side say, you crazy? This is the law. This is where my money is. I don't want to come in there. You have no capability. You don't know what the hell you are doing. You've got newbies that you're going to create inside the department to manage my money. There's an act of parliament. Unless you scrap it, can't touch it. What you're creating is a lawyer's paradise where you'll be in court, people will be sued, and because you haven't repealed this, it's going to operate to the full extent of that law. Because it's an act that belongs to you. So what should have been done was all these things that they promise here. There was a health market inquiry about all these problems that we're talking about. It was recognized. There was an inquiry headed by a judge that came up with recommendations. Where you start is by implementing those recommendations in reforming the medical schemes. You amend it to take it back to the original format of the promises that you're making inside NHI.
Is there willingness by the medical aids?
It's not about willing. These people have vested interest. They are eating. Do you think anybody that's eating and others are starving will be willing to take food out of their mouth? It's about leadership. I went back to say 1948. There was no willingness to form an NHS. But there was political leadership that was given, and that minister was supported, and you have a system that has performed brilliantly for 75 years. It was not supported. You see, when somebody gave his address about, I'm going to unban the ANC, was he supported? The
No,
majority
course
of
not.
whites were against that.
Of course not. There was even a
Now, what
referendum.
makes you... government
Mm.
means you take responsibility to lead. You take courage. When you want to fix something, you must know that anything that's broken, there are people that benefit from it.
Mm.
And you can't go to them for permission to fix it. It's not going to happen. So why you think Adrian Gore and company are going to agree to reforms that are going to take them out of business?
Of course not.
So why would you, if you are a leader worth any salt, even want to negotiate? This is your act. So instead of creating confusion and creating a lawyer's paradise for something that's going to take us nowhere, you must have the courage to amend the medical schemes to be your template. Turn the medical schemes into your national health. That's what you do. You don't create a third pot of money. Now understand this. When they create a third pot of money and they are all on medical aid, what do you think they're going to do? The medical aid is going to continue. This will be a honeypot. That's all it is.
For someone.
Because their health is not in there.
It's in there.
It's in there.
It's in the private.
At a minimum, if you start NHI, the first people that should be in NHI should be the president, his cabinet, parliamentarians, and public servants.
Well, do you think they will?
They haven't. The only way you put up a bill to go through it to be signed is if it contains those reforms. Anything else, we're being idiots to believe anything that they say. You're being idiots. Because remember, our problem is how we spend money. It's not that we don't have money. So our solution can't be creating another fund. Our solution is to manage our funds better. Our solution is to put reforms that begin to do that. HMI inquiry did the work for you. Just have the guts to do the right thing. Amend the Medical Schemes Act. And then say, anybody that's employed now has to have a medical aid. But a medical aid is not going to be run like health insurance. It's a medical aid. We cross-subsidize each other. That's why it was called medical aid and not medical insurance. Because we're coming together, we're cross-subsidizing each other. You are not being rated as an individual and somebody say, your money is finished. No, we've put our money together. The stock fell.
Yes.
The stock fell, rises, and comes down together. Medical aid, where a stock fell, those laws were changed by Rina Venter. And they are a honeypot for connected people. You want to be an administrator, not a healthcare provider.
Paint a picture for us of a world with NHI. We wake up tomorrow morning.
So just understand this. Before I paint the picture, I support national health.
Okay.
I've been a proponent of one system for all of us. What is being proposed is not it.
Then
So just understand that.
Paint a picture of what has been proposed. Tomorrow morning, it's signed into law.
Just a few things. What is being proposed is that, we're going to create this National Health Fund and we're going to create a department inside the Ministry of Health.
It'll have a board.
We've started employing, we're going to create a board. Do you know of something called a Council for Medical Schemes?
I'm aware of it. Because it also it has a board.
Yes.
It has people who earn a salary to go to work to it.
And it's a statutory body.
Absolutely. It's in law.
Oversight on medical aid funds, which is an act of parliament. Now, if you want to unite things, why would you create an administration of people that are now going to learn, that don't know what they are doing, even if they knew what they are doing? When you have a statutory body, and they are all appointed by the minister, and they are all looking at health funds, and they have 40 plus years experience of doing that. And you are creating something inside the ministry.
So
that is now a department. So it's completely under the control of the minister.
Who wins?
It is not an independent. The board is independent. Nobody wins. You just create chronism, create jobs for pals, and you have a fund that you can control who gets what, who gets this tender, who gets this. The first thing will be that, old friends of this administrator and old ANC friends have got the contract. Consortium 1, Consortium 2, Consortium 3, you get this, you get this. We don't need any of that rubbish. It's a waste of health resources that we do not have, that should be going for care, that should be going for upgrading our hospitals, that should be going for putting up budgets to be able to employ nurses that we need and other healthcare professionals that we need. Why are you duplicating? Now, what makes South African think that you are uniting when you are creating other institutions that are not going to have a right?
Because
now,
we're not aware of the other institution.
But here's a council for medical schemes.
Yes.
It's appointed by the minister. Why are you not changing its terms of reference or expanding it to deal with these issues that you are talking about?
Yeah.
So they are now being spoken for by this CMS. At a minimum, if there's going to be a sense of believability, would be to say that we're creating the NHI, but we're giving the CMS new marching orders of how this fund is going to be the oversight on this fund. You can't be creating some other things elsewhere on money we don't have, creating people we don't need. When there are people out there, I mean, it's crazy. That's why I'm saying, let's begin to ask the proper questions.
Yeah.
You can't connect these dots.
Because we don't know the dots.
Huh?
We don't, as average South Africans, we don't know. One of government officials was asked if they've consulted, and they said they have.
But you see, one of the things, it's not the education system. It's the citizens we've become.
Describe us for a second.
We gullible. We too selfish. You don't care about the next man. The country is driven by fear, where all of us want to escape. You just want to be better off than your neighbor.
Yeah.
Whereas one of the funny things that apartheid did, it put you together with your neighbor. So you had to be better together.
It forced you.
It forced you.
Separated the color, but didn't separate the people.
It forced you.
Yeah.
So in the townships, the child for the local constable and the laborer and the principal and the inspector and the doctor and the lawyer went to the same school.
Went to the same clinic.
So the lawyer and the other educated people gave credence to an SGB that had the skills, and it worked for all children. Came to the same schools, the same teacher. The teacher didn't teach here when their children or grandchildren go to a private school. We had a stake in it. Okay. Human beings are driven by self-interest.
Yeah.
And if you want a leader to help the one at the bottom, you must align the self-interest of Gogo Dlamini with the self-interest of CR. Then things will work. But we've been reduced to wanting to escape, not wanting to improve our lives. I've reflected of where I come from. And part of what has not been helpful has been the refrain where when our parents struggled, sold the shirts on their backs to take us to school, they would be saying, I want you to be better. I want you to get out of here.
That's true.
And that's what we're paying for. Because we are raised on a get out of here syndrome. Not, I want you to go to school. I want you to make your community better. I want all of us to rise.
Can I defend them for a second?
No. I'm not blaming them. And I'm not trying to find fault with them. Okay. I'm just giving you the facts.
The context.
They were doing the best that they could.
Under the circumstances.
Yeah. What that has created, it has created a culture of escape. That's why all of us take our kids to private schools, and the schools we went to are derelict. It's because of that.
We wanted to leave.
Okay, because we were raised on wanting to leave.
Mm.
Okay, and they were doing the best we can, but we got to realize that unless we want to go back, things are not going to get better. Unless we want a public healthcare system that works for all of us, things are not going to get better.
Yeah, the one that left is no longer playing a role in the place they used to live in. They are now living in a different set of circumstances.
But worse than that,
yeah,
where they have left to, they've been given this mentality that, there can't be too many of us here.
Ah.
So they have become gatekeepers to ensure that their brothers and sisters don't come in. Because if they come in, things are going to be bad.
The blacks are coming.
The blacks are coming. And it's the blacks that say the blacks are coming. You get to a private school, once it becomes too black, hey, it's too black for me. I got to move further north. Self-hate. You might not like the concept.
No, I didn't.
But I can tell you it is there everywhere. White is better. I'll tell you sad stories, even from us as doctors. When we get sick, we're going to look for white specialists.
Ooh.
We will pass our own colleagues.
And think they're not good enough.
It's automatic. It's automatic. Self-hate is on steroids.
Wow.
And unless we bring back the philosophies that were espoused by people like Robert Sobukwe and Stephen Bantu Biko, we're not going to get there. As long as we hate ourselves, we're not going to get there.
I have a feeling we're getting worse.
We're getting worse. You remember, a few weeks ago, there was this story of children that took something from a local puzzle shop and died.
Yeah, they ate some food.
And that shop was owned by a local family. Okay. But their descendant who was running that shop could not make money. And he rented it out to a foreigner who came in and was making money. And what he said made me sad. He said on national television, I had to rent this store out. I'm now working elsewhere and I collect rent from here. And the reason I sold this store is that the local mothers would instruct their children not to buy from me, but to go to the Pakistani down there. So I, as a South African, cannot survive because I will not be supported by South Africans. They will instruct their children not to support the South African. Now, I'm not telling you something it's something that was said on national television. That's what we have become. We've been so dehumanized that we think being white is better in every respect. We start talking against our customs about lobola, etc., etc. We think white is we've been made to hate ourselves.
Yeah.
When you struggle with your spirituality and connectivity, and you say, I am an African, you'll be ostracized by your fellow Africans that have become Christians.
They'll say you're crazy.
You'll be given names, and you'll be discarded. And when you look at what is happening in the world, it's only in Africa that the locals have lost their own connection to God and are dialing somebody else to connect them.
Or somebody else's God.
I believe it's a common God.
True, but
we all have our own pathways to that God.
True.
And when you lose your pathway, you take somebody else's pathway.
Of course.
What you are doing, you are making that person your God.
Wow.
Because you lose your direct entry. So they are your God. That's why with us, whiteness is everything.
It's better.
Whiteness is better. I mean, we're not supporting traditional medicines because whiteness is better. There are many remedies that are imbued in our culture, but we ignore them.
Because they're not bought at discount.
And then when somebody bottles it in Germany from a herb in Africa, we now go and buy it because it's got doctor whatever.
Jeez.
So you have to understand that our problems as African people, our biggest problem is self-hate.
And are you saying then it comes from the top? the self-hate in this regard?
No, it comes from all of us.
Yeah.
You see, the only way you deal with self-hate is by accepting that you hate yourself. Not saying it comes from somebody else. You know, by definition, self-hate
Is me.
comes from
From
self. Deal with it in that context. We
Yeah.
might deal with it in terms of trying to understand. And what happens, you must understand that self-hate is how we've been colonized, was to hate ourselves. And those that have colonized us are able to pick the best self-haters. And they're the ones that go into administration positions. And it becomes a self-fulfilling prophecy. Yeah, I mean, one of the challenges that we face in South Africa is that if you're African and you're competent and you're ethical, you are fucked.
With a capital F.
Yeah, with a capital F.
Yes.
Because whites don't want you, and your fellow blacks don't want you either.
Wow.
Because the common refrain, that one, halemo, harakhonuja,
Igira bete.
igira betere.
And what would the
And the
whites
whites,
say?
that one, he can't be controlled.
You're
They
an
ca-
island.
They can't put you on a leash.
Mm.
So I mean, for some of us, you're more oppressed
Mm.
in the new South Africa than you were in the old South Africa.
Yeah. Wow.
And that's our reality.
That's a big statement.
That's our reality.
Are you saying then we haven't created an environment where blacks are able to flourish in all sorts of aspects of life? Medicine, medical care and healthcare being our area of focus. We have created a system that continues to make things worse.
Yes, I'm saying that, but I want to put it in simple terms.
Yeah.
The world is a trading environment.
Okay.
That's all it is.
Mm.
We buy services from each other. If you go anywhere else, those that are less in numbers are the ones that are challenged. It's the minorities that are challenged. We were so battered and we've lost our humanity to the extent that even where we are a majority, we want to be affirmed. Now you go anywhere, affirmative action is for minorities, not for majorities. When you have majorities that want to be affirmed, they've lost who they are. When you have majorities that want 25% of somebody's business that they've not worked for, that they don't even understand, we lost mentally. You know, it's fairly simple. For Africans to succeed in South Africa, if you're African, buy African. Because the world is a trading environment. Whether you are buying architectural services, whether you are buying a DJ, whether you are buying music, whether you are buying clothes, whether you are buying food. But we will not support each other. So oppression
continues.
is on autopilot. And we are the ones oppressing each other. And how do you express that? That's self-hate. That's self-hate. I mean, you know, it's frightening how much we hate ourselves. And we need to accept it before we can deal with it. You know, self-hate it's like substance abuse. It's like being addicted. And until you accept that you are an addict,
You can't heal.
you can't heal.
Yeah.
Until we accept that we hate ourselves, we will not heal. And we will not succeed.
Sure.
Not as a group. We will not succeed. You know, there's this picture that I gave people to say, you know, where we are as black people, it's like we're in a pit. Okay? And the reason we're not coming out of the pit, because you're not working together. Everyone that is almost at the ledge, about to get out of the pit, everybody else inside is trying to bring them back.
True.
Into the pit.
And they're probably kicking them. So they stay.
And they are kicking to get out.
Yeah.
That's our problem. And what we need to do is to go to the bottom of the pit and have an imbizo and say, how do we work together to get out of the pit? Because that's the only way we're going to get out of the pit.
But if we say Are kukaneng, the last guy will say Nago kukakma. Because I'll be the one left behind.
No.
Yeah.
What will happen is that the leader will make sure everybody goes out first.
Yeah. They go out last.
That's Arikukanen that will work. They'll go out last. But when the leader goes out first, what you say is possible. There's a danger that the last person will stay down there. But if it's the leader out there, the ones out there that is put out there are going to make sure that their leader comes up.
They'll throw
but
a rope.
The leader must be prepared
to sacrifice
to the one who will come out first.
Yeah.
Our leaders, Komeletlo, they are not the last to eat. They are the first to eat.
Of course, they're honorable.
They don't make sure that others are fed. Even if you are honorable and they've put your food out there, your duty is to ensure that your guests eat.
That's true. Yeah.
But what we have come today, dijo di fedile man ka maswabi wena o ntse iphimela molomo ore dijo di fedile
as keys dijo di fedile.
You know I mean, if it's I put it simply, if it's national health, it has to be for all of us from the beginning,
and it should be used by all of us,
and the first people in it, just like Ribuaka, a good leader will be the last out of the pit. A good leader, NHI, will be the first into the pit.
To show all of us that it works.
To show all of us that they believe in it and it's going to work.
There's a professor in Wits University, Professor van der Heever, who says this may never happen in reality. It's too far-fetched. The thinking is too far-fetched.
No, it's not too far-fetched.
Yeah.
I wouldn't want to speak badly of a professor since I'm not one. It won't work for simple reasons. That it was never meant to work. It's meant to be a pot of money for people to chow from.
Do you think there are people who know that it's not going to work and they carry on to push for it? So they create the pot of money.
They know that it's not going to work. That's why they're pushing for it. They're pushing for it because that's where they're going to eat. And what's going to happen is that there are many people around it that believe in it. And NHI as a concept, I support it. Okay. But what people don't know is that there are people that were said, this has to replace the Medical Schemes Act. Whether you are amending or whatever, that's the only way it works. So they've come around it and said, no, don't worry. We're going to do this. And what we cover won't be covered by medical aid. And slowly, it's not going to happen in South Africa. Because if that thing is in law, unless you repeal that law, you can't fiddle with it.
And it's not easy to repeal a law.
Okay. So the best way forward would have been to amend this law. It's not like the people in medical aids are not hurting. Their only thing is that they're better off than the people that are not on medical aid.
Of course.
But both parties are hurting.
Yeah. There's nothing worse than having a medical aid and you can't get medical care because you finished your money.
Well, you know, I always tell people that if you're on medical aid, you're fully covered as long as you don't get sick.
You see what I mean? What does that mean?
Now, people are protecting that because they fear the worst.
Yeah.
So you know, people on medical aid are out of the snake pit, but they are not in the promised land.
It's a loaded statement, though.
They are not in the promised land because they also have challenges. They get bankrupt when they get sick. Yeah. They've got co-payments. They've got all sorts of problems. They get dumped by medical aid. They run out of funds. So the only way you grade there is if you don't get sick. But what they know is that they're better than the people in the pit.
Yes.
And they don't want to go back to the pit. And what they are saying is, fix the pit before you come to us. What they do not understand is that the pit and them, you part of the same coin. And unless you have a plan to fix both
sides,
simultaneously to take us to where you are not on a ledge, I'm not in a pit, we are all on firm ground. It's not going to happen. So it's not either or. It's not sequential. It's not fix that first. Both are sick, both are dying, and what you put on the table has to be addressing the challenges that both face. That's what will create a national health that is going to work. Not an independent fund with independent players. It's not addressing any of these issues. You're bringing new problems. And given the history of what they did recently with the emergency fund, what makes you think they're going to do anything different with the NHI? People stole. People created companies. A minister lost his job. But nothing has come out of it. And nobody's talking about this is what we learned on the emergency fund, and this is not going to happen, this is not going to happen. There'll be no tendering. We're building institutional capacity, etc. None of that is being said. But that's what the problems are. So you create a fund, it's going to be subjected to the problems that these ones have, because the problem is not funding.
As you say.
There's a problem about the institutional arrangement around funds. And you deal with that by amending the Medical Schemes Act, taking it to represent what it was supposed to represent: universal health coverage, negotiated tariffs, certainty for members.
That's it.
That they're going to get the care that they need when they need it, so that they can happily pay throughout the 40 years of employment when they're healthy, knowing that when they get to year 45, and they've not claimed for 44 years, nobody's going to tell them they've run out of funds. What's the money that I've paid for 44 years? We're not asking those questions. But because this is better than being in the pit,
I'd rather choose this.
you'd rather stay there and be silent. Even though, it's like, you remember at the height of the HIV pandemic, and people were claiming that if you sleep with a virgin, you'll cure yourself.
All sorts.
And raping of our women was at a high. And you had women that saying, at least if you rape me, use a condom. You should not be raped. Should not be raped. So people on medical aid stop saying use a condom. Say, I'm not going to be raped. And we're going to build a better South Africa. Health gives us an opportunity to unite this nation.
Are you saying NHI is driving the division even further?
You're creating a third fund. How are you bringing everybody together? Everybody is in the dark about how it's going to happen. Everybody is doubtful. Okay, you are not coming up. You're going to appoint new cronies, new board, new this, but you are not talking about closing the taps of corruption. You are not talking about procurement. You're not talking about line budgeting. You're not talking about ending cronism. You're not talking about outlawing political interference. Esidimeni was about political interference. And political interference continues to date. It's embedded in the system. You create a board, a minister appoints a board, but a minister then appoints the CEO for the board. How is that CEO going to account to the board when the CEO is appointed by the minister?
That's true.
And that's why things don't work. Those things there's nowhere where those things are being fixed.
It sounds like you're talking about ESCOM, but it's a different discussion. We will not get there.
I mean, it's ridiculous.
Yeah.
Simply put, you got to build a system where the president goes to, and Gogo Lamini goes to, and you and me go to, from day one. You can't be creating a pot of money and all these things must be imagined and believed. Building a health system is not a religion. It should not be about believing. It should be about facts on the table.
Yeah. You have said that this is a political policy. Nothing more than that. What is political about it?
What is political about it is that, let's face it, the ANC is on the ropes. So one of the things that you want to do is to come up with policies that appease the masses. Promises, whether they are implementable or not. I'm saying this is health. This is not like something that we don't know anything about. We should not be talking about promises. We should be talking about a full roadmap that's put on the table that all of us can see.
Yeah.
Not promises. Not promises. Because politicians promise, and there's no legal way to hold them accountable for the promise. If they don't deliver the promise, they don't go to jail. So they just polish it next time. And given where they are, it is important that a fuzzy, warmy policy come out that gives people hope. That, they are saying, I'm going to have
Free care.
Free care. What people don't realize is that a public health care is free care. The fact that it's free doesn't mean it's going to be good quality.
Yeah.
So they are promising you what you already have. Free care. So what is it that you are missing? What is it that you are being led into?
I'm missing free, better care.
But there's not making a pot of money does not make the care better, because the care was not better because you didn't have money. Do you understand? It's like saying, I got car trouble. I've got an engine problem.
Yeah.
In this beautiful car of yours, whatever it is. But to fix the engine problem, I'm going to buy a set of new tires.
Yeah. Fixing the wrong problem.
You're not addressing the problem.
That's why
You're not addressing the problem.
That's why I keep asking. I am sick. NHI exists. I am sick. I can go. I'm unemployed and I am sick. NHI exists. I have signed up to it, whatever process that will take, and I can go to any healthcare service and they will attend to me because there are funds available to look after me, even though I have not paid for it.
When you say any healthcare service, what do you mean?
Private healthcare.
A right of admission is reserved. You see, if for them to do that, they got to have negotiated with the private provider.
Of course.
He's got to get proof that you're one of those that they've negotiated for.
The assumption
there has to be a legal guarantee, like used to be with old medical aids.
True, yes.
Where payment was guaranteed and it would never say you haven't sent the account in 2 months. It never expired. I've delivered the service and you must pay me.
True.
Okay. There's none of those things. And we are saying the HMI spoke about those issues. Those are the fixes that you should have been doing. That's the only way it's going to guarantee you that that fund is going to get you into that clinic. As if there's a tariff, what makes you think NHI is going to come tomorrow and they're going to be able to negotiate with the hospitals a tariff so that you can go in there? When currently, under the current privileged fund called medical aid, they can't even do that. Why don't they do the reforms to do that, and you're bringing people onto that template, in which case you don't create a new fund. You reform the
existing.
You reform the medical aids and you say all others will join the medical aids. It's been fixed. You know that. You produce it at a hospital, you get seen. As we have fixed the medical aids. It used to be like that before medical aid. It's not like that now. Now you got to get authorization, etc., etc. And until that happens, you're not going anywhere. You're not getting anywhere. Did you understand what I'm saying?
I hear
it's
you
all
100%.
this promissory note where everybody, it's like, have you been conned?
No. Personally, well, yes, but it's a small.
And when you get conned,
yes,
they give you promises.
Of course.
And you buy into that. And because you never went into the details, you end up being conned. This is a promise. We've been conned before. We're looking for the detail.
But that's why I ask, and that's why you are here, to describe the scenario when NHI exists and I fall sick and I'm unemployed. It says it's universal. It says it's free. It said it's the best health care. I'll get the best possible health care for free.
But I've just told you
that it's not.
That's not going to happen.
Then what's going to happen?
They'll have a fund that they'll raid. That's what's going to happen. Yeah. And they'll still be on medical aid, go into the private hospitals under the current arrangements between their medical aids and the current providers. Or you come in, they say, that there's a co-payment that you have to pay up front according to your benefit.
True.
This is the contract that we have. And that's what's going to happen. And on this side, fuck all is going to happen.
Nothing. So our people
Fuck
remain
all
the
is going to
same.
happen. What they're going to tell you is that, don't worry, you're on national health insurance.
Yes.
Your hospital care is from a public hospital.
So nothing's changed.
And when you go there, they'll take this.
Ah.
Nothing's changed. You can go there for free now.
No.
Nothing's changed. So the promises that they are making are what is being delivered
Right
by
now.
current public health. Any of us can go there. There'll only be issues of jurisdiction. What address do you give? Are you from here? La 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 la. Then you come in and access is free and nobody wants for anything. We just tell you, hey, the medicines are finished. Just like happens in private health. Oh, this is not covered by, this is what you need, but your medical aid doesn't pay for that. They pay for generic. I'm not too sure if it works. And they only pay for 2 months and you need 3 months treatment. Same thing, both sides.
Sure.
Same thing, both sides. And South Africans, wake up. We're being banged. Medical aid, public health. We need to fix both of them. And it has to be a simultaneous process.
Not
So any bill that fixes health has to come with those things. And we no longer want promises. We want a roadmap.
Let's go back to the political question. What do you think is the reason the provinces approved this at a relative ease? Because some say they will be losing budget and that part of their budget will go to national. But you would expect some resistance from the provincial governments, but they seem to have approved it quite easily, except for one, which is the Western Cape.
Yeah, because provincial lists are made by parties.
Yes.
And we have a party system. Once a dominant party has made a call,
Head office call.
there's nothing you can do. You can say what you want, but they tell you, if you don't vote according to party political lines, we will remove you. And we put somebody else that will listen to the party. It's that simple. So all these things, it's just noise and procedure and all those issues.
Yeah. Has this moved faster than normal in terms of white paper, green paper, white paper?
This thing has been moving at a snail's pace.
Yeah.
Health reform started with Nkosazana in 1999. And because there was no room for anybody eating, it was a room to make a system that works, where people will have access to providers. Providers will be guaranteed income.
True.
And members will be guaranteed care without any Knoxman getting any money. You don't need to know somebody to get a contract. Nobody's going to administer. They'll just create a template where we collect information and we put it into a central database so that people can collect public health information to say, we have so many cases of this, we've used so many tablets of this drug, etc., so that you can plan and buy better. It was not supported. That was 1995.
Yeah.
So you can't call this moving too fast.
It's very slow.
It's very slow. We're getting nowhere very slowly.
However, it looks like the past 6 months have moved fast.
You see, the point is, the past 6 months has moved fast because this, if you get this signed, it's a campaign tool. It's a promissory note to get votes. And after they voted you in, it's back to normal. You carry on your medical aid. You now even have a new fund to raid. But you're going to deliver squat.
So you're saying, okay, what are the fears that some legal, constitutional concerns that medical aid owners and companies, big ones, seem to have against the NHI? What are some of their concerns? Or they're assuming it's going to be implemented?
It's simple. If you start the road of NHI, you are threatening their business.
True.
They don't know whether you're going to be true to your word or not. But they're going to lose membership.
Because if it works.
They're going to lose membership.
If it works.
But they're going to lose membership.
Yeah.
If it works, becomes something down the horizon. If you come up with all the promises that you make and the fund stands up and the fund says, mine worker, for 1,000 rands will get you full coverage. And currently mine worker, they're taking 3,000 rands from you. What are you going to do?
Of course, I'll move to
What happens
NHI.
What happens to medical aid when you move?
They lose a client.
So where's their interest?
Mm.
Why would they support something that's going to kill them?
Yeah.
Huh? But the problem is that there'll be so much confusion. And if you don't do it right and you're not bold enough to do it properly, don't do it at all. Because you're giving national health a bad name.
Let's talk about funding. We seem not to have the money for it.
No, we have money for it. But that's why the way you do it is you do it on the current money that you have.
Okay.
You're not trying to build more money. No one in this healthcare system deserves to be given more money until they utilize the money in the system better. That's the first reform that you need to do. And you can do that by ensuring that you amend the Medical Schemes Act to ensure that you have certainty about what you're covered for. The providers have certainty about being paid. They are properly negotiated rates. Do you know what used to happen with medical aids? You'd come out and there'd be a tariff that's negotiated. The association would be there. The medical schemes would give themselves a discount and they'd publish a tariff.
Okay.
And you as a doctor had to decide, am I contracted in
Or
or
not?
am I contracted out?
Yeah.
If you're contracted in, you're taking medical aids. And people that come to see you, there's no co-payment, there's nothing, they get the full care that they need. If you don't like those rates, you're private. That's what the term was. Are you contracted in
Or not?
or are you private?
If you're
So
private, how do you
is
make your money?
outside. Huh?
How do you make your money if you're
No,
private?
private means
Cash.
I don't
I don't
charge
subscribe
those
to
rates.
this. Yeah.
You pay me cash. You pay me what I ask of you, and I will give you a receipt of what you paid. And you can go claim back from your medical aid if you want. I'm a private doctor. It's between me and you.
That's it. Yeah.
That's what private is.
Yeah.
That's what private is. Well, anything where there's a group of you and there's somebody screwing you for money, stealing your money, that's not private. That's privatized. That's medical aid. Medical aid is not private.
Yeah.
When you go and see a traditional healer, that's private. When you go and see a doctor and you don't have medical aid, that's private. When you go to a private hospital and you got no medical aid and they say deposit, that's private. All others, it's not private. It's privatized. If you go back to where we started, where they privatized white public health. That's all it was. And when they privatized it, it still had the guarantees that they had from a white public healthcare system.
Gotcha.
Where it's full coverage, no payment at a point. In the front door, the public healthcare system still operates in that manner. Except that once you've opened the door, you're not too sure what you're going to find behind the door. Floor beds, not enough.
And that's the
staff,
fear,
not
isn't
enough.
it?
No, that's not the fear, that's the reality.
Okay. Yes.
That's the reality.
Yeah. Yeah.
But there's universal coverage to poor care.
It exists now.
It exists now. What we need to do is to make sure that it's not poor. And on the medical aid side, we need to ensure that quality is improved because there's also a lot of bad medicine in the private health.
Yeah.
But also that there's universal coverage.
Are you saying private healthcare is not as shiny as it looks?
No. Oh, private healthcare is not as shiny as it looks. Overpricing. I mean, we're losing money. This side, you're losing it to overpricing, to corruption, to paying for things that are not needed, like exorbitant admin fees. This side, you're losing it to tendering, procurement, corruption, and poor organizational structures. You're a CEO, it takes you 6 weeks to fix a broken window. Okay. I mean,
it sounds irresponsible.
Those are the challenges that we face. That's what needs to be fixed. So what you need to be doing is need to ensure that people on medical aid have access to universal coverage. Okay? And that their money is utilized better. And that you use the power of a parliamentary system to buy better. You don't buy as this medical aid, that medical aid. You negotiate, just like you're going to negotiate tariffs for professional fees. You negotiate what you pay for a panado and who's going to supply it. That's how that wide public healthcare system operated. Okay. And there was no Knoxman, friends, and outsourcing.
Administrators.
You built capacity. Okay. Equipment and technology was acquired by the system. The one that did the first heart transplant, that operated on Tony Factor, the technology was owned by National Health. It was inside the public sector. That's what you do. You don't have people trading with technology, trading with equipment, doing unnecessary MRIs, doing unnecessary blood tests because they earn money every time they do a blood test. You professionalize the system. The providers get professional fees. They don't work like traders producing a till strip. The longer the till strip for the patient, the more money you make. No.
Is that what happens now?
That's what happens now. That's what happens now.
Yeah.
I order an unnecessary test, I make money on it.
Huh.
Because that's how I get paid. I'm not getting paid as a professional. If you pay me a professional fee, the way Chris Barnett was paid, a decent salary, can move in a middle-class suburb, your children can go to school, you can drive a car, you can afford to pay your bonds, and live like a middle class.
But now we have
For lack
different,
of a better
we
way.
have different ambitions now. It's not longer a middle class life. It's slightly higher than that.
No. Most doctors just want to be able to live in society and afford to have transport to take them to work and serve society.
Yeah.
Most doctors want to serve the public. They don't have aspiration. You want to be a millionaire, go own a game farm. But what you can't do is equate practicing of medicine as a professional
to
not
wealth.
being able to pay school fees for your children. We're not talking about private jets and any of that jazz. No.
It brings us to an interesting one. We've spoken in this very room about unemployed doctors, how the system has been unable to employ doctors. Why has that become a fact?
Because we're not using our resources adequately, because our systems don't work properly. I mean, if I was the minister, I would introduce line budgeting.
Which means?
Which means you run an institution, you come to us with a budget.
Yeah.
You say, this is my budget for human resources. I'm a 400-bed hospital. I need 600 doctors, 2,000 nurses, 10 laboratory technicians, whatever. These are the salaries. This is my HR budget. I have 10 theaters. I've got an investigation unit. I need 2 MRIs, 1 CT scan. I need a lab that has the capacity to do so many bloods for so many patients. I need so many security. I've got a line item for maintenance. I've got a line item for upgrades, etc., etc. So it's budget. Okay? And once you've given us your budget, we fund you and we hold you responsible. Do you know that Bara has never been given a budget that would be equal to the previous year's real expenditure?
Is it higher or lower?
Much lower than your real expenditure of last year.
Wow.
Not in inflation adjusted. I mean, the people that run those institutions are miracle workers.
Jeez.
Because they are given impossible tasks and they've done pretty well for that. So you create line budgeting. You're not going to run a health system on discretionary spending. There's nothing like that. And once we've given it to you, then you know you got your full complement, you had a budget. Now they have posts, but there's no money to pay for the posts because the money has gone to fund things that are not necessary. They bought skinny jeans with the money.
Hey, don't take us there.
I mean, instead of money going there, every MEC that comes in with their own team, political team.
Yeah.
That's where the money goes to. Political appointment. I've got 10 advisors now. I don't know the job. I've got 10 advisors. I came with my own team. The other team, because we're from the same party, is still there. So what happens is that pressure on this budget, it goes to things that are not necessary. But where do you freeze? You freeze where it's necessary. You freeze where it's necessary. So you can't employ doctors because you're spending the money on frills.
Where we are, it doesn't seem like the unemployment of doctors. In the words of Dr. Cedric Sihlangu of the Doctors Association, it doesn't seem like this is a problem that will be solved anytime soon. schools will be producing great doctors,
but
but
you
they'll
see-
stay unemployed for
You
long.
see, professionalize health service. Take out all these people that don't add value. Plan properly, and all those things will be sorted out.
Yeah.
Okay. You say you certify hospitals properly. If you're a 400-bed hospital, this is the staff complement that you need for those 400 beds. And if that's the staff complement that you need, this is the minimum HR budget that you need. Is that line item certified? Now we give the provinces money and they can do as they please with the money.
Sure.
And that's why they'll take it to political offices and other things. And there are no frontliners. There's no money to employ frontliners. So, but once you've done your structure, you say, this is what you need. MEC, what does the MEC do? I mean, do we need them? No, we don't.
Yeah.
You have one party that has won. You have one health policy that you are implementing. You don't need 10 policymakers. You just need a minister, and then you deliver. So you make health a national competence. So part of a national health reform would be to say health is a national competence. So you don't need 9 MECs. Like SARS is a national competence.
There's a commission.
SARS is a national competence. You don't have a SARS commissioner in Gauteng, SARS commissioner. There's only one in the country, and we have offices elsewhere. Do you know how much you save from that? On political appointments that add no value in healthcare. Now you have money to employ nurses. Now that part keeps increasing. Where do you think that money comes from? From frontline health workers to backroom dwellers. And you got no money for that. So I would introduce straight line budgeting. What do you need?
Yeah.
So even for a political office, there should be a budget. I mean, you're an MEC, there's room for one advisor. We one party. This advisor is an advisor to the party. It's not an advisor to you. So when you get rid of you, that advisor remains to advise the next incumbent. But no, it doesn't work like that.
They move.
They move. There's this, and that's where the wastage is. Now, it doesn't matter. You can create a national health fund. It's going to create more cronies. Unless you reform all those things, this is not a solution. It's not. You're creating a third port.
Yeah, it's concerning because we seem to be steamrolling. And in an interview you've done very recently, you speak of rubber stamping, that this is definitely going to be rubber stamped. It will become a reality.
This is rubber stamping.
We can't ignore it anymore.
It'll become a reality on the statute books. And you see, what's going to happen is, as long as they don't touch medical aids and its structures, they can create.
So these guys are safe.
They can create this. There'll be a truce. We won't touch you.
Are you saying this is where we're
we'll
heading?
create a trough.
Are you saying that's likely where we're heading? Where separate development, do your thing, don't bother us.
That's the only thing that I see. Because there's no policy framework that says the first people in here will be MPs. Because if you put MPs in, they say, PAMED, you are the first inside NHI. The medical schemes can't go and object to say, hey, parliamentarians come this side.
No.
Why is it not there?
Yeah.
So what makes you think? Lebadumedi. You're not looking at facts.
Yeah.
You are believers. You can't build a health system on beliefs. This is not a religion. So we vote like we are religious.
Over 40 million South Africans are not on privatized healthcare, medical aids. That's part of the argument that says this needs to be reformed. We have to create an environment where 40 million South Africans know when they're sick. What do they do? Where do they go? And there's a fund available to look after them.
Are you talking about the 40 unemployed?
Unemployed or employed, because not everyone necessarily has a medical aid, even if they're employed.
Yeah, but remember that part of the things that I was against was the concept of national health insurance. Because the National Health Insurance Fund will only take care of people that have paid premiums to it.
Yes. So the unemployed are not looked after.
The unemployed are not part of the National Health Fund.
But this system says we'll look after everyone equally.
No.
employed or not.
No, not as an insurance. Remember, if people pay premiums to me and I'm a board member, my responsibility is to the premium payers.
True.
I'm not the government. I'm a fund.
Yeah.
Why would a fund take care of people that didn't fund it? It's not its responsibility.
That's true.
It's not its responsibility. So I don't know, where do people think this is going to happen? Now, if you have, can you imagine? There's 40 million.
Mm.
Of those 40 million, 5 to 10 million are employed. The other 30 are not.
Mm.
So I say you're going to collect premiums from 10 million.
To
That's going to take care of 40 million.
To fund everyone.
And you expect quality healthcare from that? What is it that we don't get?
Yeah.
It's about hoping that you'll be one of those that will escape from the pit. It's not going to happen.
Are we genuinely delusional in this regard, with regards to the real making of the National Health Insurance Fund? Are we in fool's paradise?
No, we're not delusional. We've surrendered our agency.
Mm.
We're using what is between our ears as an ornament. What is between our ears is not just the sex organ. It's got brain power.
Yeah.
Let's use it. Let's start thinking. Let's start asking questions. Let's start saying this doesn't make sense.
But at this stage of the process, it seems like we've lost. The ship has already left.
No, the ship has not already left.
Yeah.
If you are not convinced with their answers, vote them out.
Well,
I mean,
that's an option.
what do you mean the ship has
that's
already
an
left?
option. Yeah.
This is a political campaign. I mean, if you think they've made other promises before that they've never kept, this one, it would be impossible for them to keep it. It's not about, there are some points where I agree with Alex. Ain't gonna happen.
Mm.
And they are not dumb not to know that it ain't gonna happen.
This is not
So I don't think they are planning on delivering it. It's a promise to stay in power. It's a ploy to stay in power for 5 more years.
Wow. And we are just the political pawns in the game.
Oh, we just the idiots. Political pawns have the sense of being idiots in the game.
Wow.
They are useful idiots.
So the only way out is elections.
I mean, you got to engage them and say, this is not going to work.
Mm.
And I mean, like you said, they go to public hearings and none of them can answer these things. When you ask the questions, the people that are there, they say, no, we're just a committee. We didn't write the bill.
Mm.
It's written by the department. We're just here to listen to the public. And we'll take your comments into account.
That's it.
That's it. So it's not even an engagement to say, what do you think? You're not speaking to the authors.
Mm. You're speaking to
You're speaking to party members that they say, we're just a committee. And by law, we have to come and listen to you. But it's not our bill. We didn't write it.
So you say, because they speak a lot about public consultation. That's something that comes across a lot in most of the content that I've read and I've seen with regards to NHI is that they've been everywhere and everybody knows.
But what does consultation mean?
It means I come to you and tell you that I want to paint the house and I think we should discuss it and find out.
But do you know that they are not public consultations?
Mm.
So don't make them consultations. Do you know what they call them?
What do they call them?
They call them public hearings, not consultations. Because you come to hear the public. You don't even have to engage with them. You don't have to answer them. You just hear them.
And then walk away.
And then you've conducted the public hearings. Because consultation would be engagement.
Mm-hmm.
Consultation would be someone saying, that doesn't make sense. Explain it to me.
Yeah.
But they are not there to explain. They've given you what the bill is. They want your comments on the bill and they are here to listen to you. That's all the public hearings are. It's not consultation.
Mm.
It's hearings.
Wow. Are we in shit here? In simple English.
I wouldn't say so. We've been too starved to produce any shit.
We haven't eaten.
We haven't eaten.
We're unlikely.
So we're unlikely
to produce anything.
Yeah.
Yeah.
But we are in trouble.
Yeah.
We And I think, the problem is not them. The problem is us.
Yeah.
We need to wake up.
Hmm.
We need to wake up. If you can lie to people and they put you back in power and you continue living your grand life and things keep deteriorating for them and you come back in 5 years, they put you back into power. What do you have to worry about?
It's not.
What do you have to worry about?
Yeah.
You just lied to them.
So you'll be back.
And these are believers. These are not people that use their brains for critical thinking.
Mm-mm.
They are believers.
Yeah.
Why do you think apartheid was based on religion? It's about believing. When your fellow whites tell you these are inferior human beings, you believe.
Yeah.
When Netanyahu says Palestinians are not human, Israelis believe.
You believe. Mm.
And this is a belief system.
Sure.
It's a belief system.
They speak to our emotions. What else do we do?
It's a belief system. When there was the issue of a government that was not providing ARVs, with the evidence out there, with people dying, when I engaged other doctors, they said, no, but, the ANC can't lie to us. We believe in them.
Sure.
There must be merit to what they say.
There's more science to this.
There must be merit to what they say. Even when people were dying, and when you give them ARVs, they rise from the wheelbarrow and walk home.
Mm.
People still said, let's believe in them.
Sure.
Let's believe in them. Because we don't like facts.
They're too.
We like utopia.
They're too complex.
The facts come with responsibility. We don't want responsibility. We want to blame somebody else. So we don't want to apply our minds so we can say, but we believed in you. You lied to us. Because we can abdicate personal responsibility.
Mm.
When you believed, you become a victim. You don't take responsibility.
That same
you
concept.
Believe somebody else.
That same concept can be applied to a lot of other sectors in society, not only to medical care. And are you saying that that's really where we're stuck as a society, because South Africa is not becoming a better country?
No, society is not becoming a better country.
No, some would say it's literally every minute it's getting worse and worse. Police system has collapsed. Healthcare is becoming a problem on education
because
system.
There's no critical thinking. I was looking at something that says the churches in Europe are empty. Because you know what?
Mm-hmm.
Europeans have moved into critical thinking.
So they are not just...
They think about these things. And they've seen through the ruse of, government squandering money, abusing you, and you go on a Sunday or a Friday or a Saturday, depending on denomination, to go do kumbaya and come back to be abused for 6 days in a week.
Mm-hmm.
And you go back kumbaya.
Again.
No. They've left the kumbaya and they're asking for accountability.
And that's not where we are.
We can't eat religion. Where's the food? How did you manage the budget? Okay. So we're approaching NHI like a belief system. And you're hoping. No, it doesn't add up. Connect the dots. There are no dots to connect. It doesn't add up.
I have a different opinion about it being a belief system. I think it's a system that is happening all on its own. The majority of South Africans are not quite engaged at all.
Yes, you see, believing is much easier.
True.
Than thinking.
Because it's happening. It's a train that's moving past your
because
township.
Remember, when you believe, you don't have to explain. You don't have to give rationale.
Yeah.
And sadly, you don't have to account. Because you believe, it becomes the promiser's problem, not yours.
Yeah. The one who promised.
The one who promised.
They must solve it.
Yes. Belief system, it's like socializing acceptance of being conned. That's what it is.
We've accepted this, eh? We've accepted the system for what it is. And it doesn't look like we're getting out of it anytime soon.
But I can tell you, it ain't gonna work. And you see, this is where they have made a mistake. Because as we speak about these issues, the opposition parties are going to caught on to it, and they are going to say,
wait a minute.
29 years later, they promised this, that year. They promised this, they promised this. What have they delivered?
Yeah.
What have they delivered?
Yeah.
Just recently, they got funds for emergency funds for COVID. What did they do with them? What did they do with them? And you think this fund, they're going to behave differently on this fund? On what basis? What's changed?
Jeez.
What's changed? Nothing's changed.
Not much.
Nothing. Don't say not much.
I'm trying to soften the
Nothing's
blow.
changed. It's still the same groups. And they still have the same pattern. Any one of them that changes from being Saul to Paul gets excommunicated. He gets thrown out of the party.
Yeah.
You see the light, you say the people deserve better. They throw you. You say, let's stop stealing. They throw you out.
Is there hope? There must be hope.
That's a difficult one. You know, hope on this planet, on this earth,
right now,
can't go around beliefs, the past, and comfort. Hope will only come out of moving out of your comfort zone.
That's true. When you don't have a choice.
If you stay in your comfort zone, there is no hope.
But this is not comfortable.
Yes, it's not comfortable. But you are comfortable in the spot that you are in. And that's why
as bad as it is.
Yes, and that's why you won't move for change.
But the average South African is not comfortable at all.
Yes, but they are hopeful. So they are not going to change their vote.
That's the
Even
hope
though
I'm talking about.
It's a fool's paradise. It's a fool's paradise. We've been hopeful for 30 years. We've voted, 5 times?
Yeah.
We go Madiba, Thabo twice.
Zuma twice. And
Cyril once. We voted for Cyril.
Yeah, we have. Are you questioning our vote? We have voted for Cyril once.
We've been hopeful 6 times.
Yes.
And with every hope, things have gotten worse.
We didn't vote for him in the first few months of his presidency. Remember, there was a shift of power.
But he's been voted in.
He has been.
He's won an election.
Yes.
6 times we've been hopeful. And every time, post-Thabo, there was still, things were not great. We had people dying, HIV and AIDS started then. So we've been hopeful 6 times.
Zimbabwe denial issues.
And with every occasion,
yeah,
things have been getting worse. So what makes you think 7th time, you're going to be 7th time lucky?
Maybe we are. There's some who will say, listening to this.
Hope is not a plan. That's all I can tell you.
There's some who will be watching
Hope is not a plan.
I hear you.
That's why I'm saying, NHI, show me the plan. Where are the details? We know what the challenges are with the system. Can I see from your plan how the challenges are going to be addressed? Wait for later.
Yeah, we're still working on it.
If you were truthful, that would be the point on which you convince the voters. Here's the plan. This is how we're going to deal with shortfalls for people on medical aid, not being universally covered, them being bankrupt if they get sick. This is how we're going to deal with no money to employ healthcare professionals, drug stockouts, facilities that are breaking down, etc., etc.
Yeah.
And these plans, this is how they're going to do. They will be funded from this side. We're going to fund it from the National Health Fund. You fund it on what basis? How will the hospital be a supplier of services to the National Health Fund? What service will they be providing to the National Health Fund or the members of the National Health Fund?
But what do you say to those that are saying, but this is a process? You're expecting this to be a bill and immediately be implementable, but that's not how it's going to be done. It's going to roll out. It starts with the bill.
That's why we have policies that have never been rolled out, that have just been given new names. Yeah. RDP, this and that. We're tired of your bullshit. Go back to your history. You've just changed names you've never delivered. Now we want to see the pro forma, delivery platform. We want to see it.
Not this time. It might not happen.
Huh?
You
Then
say-
if there's no pro forma delivery platform, it means it is not going to be delivered.
yeah,
That's all.
you're just talking.
That's all. This is just talk. Why do you know? It's like the relationship with the new government. It's like being in a relationship with gender-based violence,
And being comfortable with it.
and they keep telling you that it'll get better, but there's nothing. There's nothing to show why it would get better.
Then in this
It's
regard,
just hope. And what's going to happen? You're going to die in that relationship.
in this regard, then, with regards to NHI, there's nothing to worry about then, because it's not going to happen.
No, there's something to worry about.
Okay.
Because the fund will be formed.
The fund will be there.
Yeah. But there'll be no changes. Things are going to get worse. You'll have a third tier, and that's where they'll be eating. Trust me. They're going to form the fund. But none of those things that they promise you are going to happen because there's no roadmap to make them happen. So you can't tell people that, I'll only know how I'm going to do it once I have the money. It doesn't work like that. Doesn't work like that.
Don't you want to be proven wrong this time with regards to thinking that it's not going to happen?
No, that's being an idiot. Just put the plan on the table
That's
so
it.
that we can give you critique and all that. I'm a scientist, and let's work on facts. You can't deliver medicine on hope or on divinity. We want to see the plan. Show us at least you've approved an HRH plan, Human Resources in Health Planning. How are you going to fund the posts for doctors? Where's the money going to come from? How are you going to track it from the National Health Fund to fund jobs?
Yeah.
When it's not paying for services delivered by the doctor.
I go by.
Just connect the dots for me. Hadikopani.
Yeah, not this time.
Hadikopani.
Yeah.
Hey, you are way ahead. Hey, no bull. You could at least give us a framework of how it is going to work. We are not saying appoint the doctors now.
You realize that you've painted the worst possible picture of NHI in its current form. And there are those who believe in it like a religion. There are those who don't know much about it. But you're saying this is just
I'm the
nonsense.
first proponent of NHI, but this is nonsense. You're creating a third tier. You're creating more difficulties. You're creating a fund for eating. You're not sorting out our problems. Our problems are not money. Our problems are how our money is managed. So you are not even saying, this money, this is how I'm going to manage it. You're not even telling us that. You're not even telling us that. You're telling us you're going to have a board, you're going to have staff in there. There's a board, there's staff, there's CMS, there's trustees in medical aids. There's fuck all that's happening. There's hospitals, there's hospital boards. There's fuck all that's happening.
There's a board at ESCOM.
There's a board at ESCOM. There's fuck all that's happening. So don't come and tell me you're going to create a board.
Yeah. A board is not
what?
a board is not a magic wand.
A board is not a magic wand.
Yes. Oh hell.
And when a board tries to do its job, the chair gets fired.
Of course. Well, yeah. Well, arguably he quit. If we're referring to the problem, you go Megawatt Park.
No, he didn't quit. He was fired. The point is, if you being turned into a dummy, and you can't make your board work, if you have principles and you are worth anything and you are not there to eat, you'll walk.
You leave, eh? And that's what happened.
That's what happened.
Do we as South Africans listening to this and feeling worse than when we started this conversation, what role can we play, if any at all?
Stand up and be counted. Stop being
An audience.
an idiot.
Yeah, and an audience. I choose a lighter word.
No, stop being somebody's useful idiot.
Yeah.
Where you come in, you vote, you come back post the election, fuck all happens. You come back. We've done that 6 times.
What do you say to those that will say Dr. Letlape is just anti-ANC? Nothing more. That's a sweeping statement, I'm aware. But there's some who will say, this is just another anti-ANC a person who's got his own personal grudges, which I'm not aware of.
I'm pro the people of South Africa.
Yeah.
I'm a health worker through and through. And the people come first. Don't care what party they are in. Okay. I faced the party before when they were denying people ARVs. I've been called names before. I stood. I was part of a process that put ARVs for the first time in the public sector.
You've seen this before.
I've been through this movie before of being labeled, being anti-ANC, being anti the president, be pro-pharma companies. I've got a T-shirt, I've got the scars, and it doesn't faze me.
Yeah.
I put people first, not parties. I'm a doctor, and my ethical oath is to the people. It's to my patients, not to my party or my bank manager. No. So you have a right to say what you want to say. But this is an opportunity to have something that works for all of us.
Yeah.
You know, there were no Springboks for the poor. There were no Springboks for the rich. When he came up with his team, he was criticized for lowering standards, etc., etc. He gave us a captain that brought 2 back-to-back World Cups.
Miracle.
But the key issue was one South Africa, one team. And the secret in the team was it's about the team, not about individuals. So when we have opponents, we choose the best team for that opposition. Even if it might mean one of our best players is not going to be effective against this team, and we put them aside.
Yeah.
That's leadership. If it doesn't work, we take it on the chin. Okay. And I'm not about, I'm not young anymore. And I'm not about, he was right or we told you so.
Trying to prove something.
And I have a history and I want things that work. I've been there. I've seen it all. If it's about reform, we must reform the 2 parts that are misfiring to create one. Bringing a 3rd part is not going to bring the 2 parts together.
What's an ideal healthcare system for you, in conclusion? If you had to create one tomorrow
an
morning.
ideal healthcare system is a healthcare system that is for everyone, from the poor to the president, that has common entry points for everyone.
How is it funded?
Where we build solidarity, it's funded from the people's money. That's how it's funded.
Same way we fund everything else.
Same way we fund everything else.
Yeah.
We fund the roads from people's money. And it's about solidarity, cross-subsidization.
Is it?
And you will, if you earn more, you'll contribute more.
But
if
do
you earn
you get
less,
better care?
you'll contribute less. If you don't earn, you can't contribute. But we are in this together. And we are building a healthcare system for all of us that is owned by all of us, and all of us have responsibility in making it work. And there's nobody that can build a healthcare system that can take care of a people that are not going to make themselves healthy. So even though we have a healthcare system, you got to promote well-being. You got to promote health. You mustn't build a sick system where it waits for people to be sick so that it takes care of them. You must build a system that will make sure it has all the measures to make sure people don't get sick. Squatter camps, crowding, places for spread of infection. We wonder why TB is the highest killer when we are not sorting out our habitats. Yeah. TB is spread in crowded environments. Why can't we outlaw squatter camps? That's when we're talking about health system, we're talking about those issues. We're talking about access to food. We're talking about clean water. We're talking about proper management of waste. We're talking about proper environmental management. That's what health is about. It's all these things together.
It's an entire system.
It's not about a system for the sick. So ideal health system is where the population is educated about what it means to be healthy and that you are responsible for your own health. And then if you take care of yourself, you are making the health system work. It's about how we help each other in times of need. It's not about you, it's about us. When you contribute to it, you contribute to it when you're still healthy and you can contribute. So when you're not healthy and infirm, it can take care of you. That's what a healthy system looks like, where we are all in it together.
If I
A
earn
healthy
more,
health system has to look like our voting system.
if I earn more, can I get better care in that health system? I earn more, I contribute more. Surely I deserve better.
No, you don't deserve better. If you have a challenge with earning more, the way to fix it is to make you earn less and will still give you the same benefits that you'd have got even if you're earning more.
I'm a high contributor to the system.
It doesn't matter, you're a high earner.
Yes.
Find another country. In this country, we hold each other's hand. And that's why the Springboks brought it home. Because as Siya Kolisi kept saying, no player is more important than the other.
True.
So you are saying others are more important. You don't have a team, it's not going to work. So people have to understand.
Isn't it valid for me to ask that I contribute more and there are people who contribute nothing?
No.
But they get the same care as me?
My answer to you is that in the port, the people will get the same care as you. Okay. But you earn more. You know what advantage you have? You can do your side thing on your own because you can afford it. You can go to Dubai. We can't go to Dubai.
Yeah.
So you have the means to do your own thing on the side without destroying the solidarity. You also have the choice to go and make your money elsewhere. If you don't like the value systems that we have here, nothing forces you to stay here. Go make your money in Namibia. Go make your money in Zimbabwe, where not everybody matters. Here, our social ethos is that we are in this thing together. If it's going to be a problem for you that you make more money than the others, there are societies where if you earn more, you're have better. You're honorable and you'll be treated differently. Not in this country. If you don't like our value, go make your more contribution where you will be made a king. Here we're grateful for you and we're happy for you. And we hope you make even more so that you can contribute even more. That's all.
Some will argue and say this is a socialist system that encourages laziness and where people don't work so hard because they don't work, but yet they get the same care as the president. Some would argue that and say, well, what incentive do I have? I don't have to work. I'll be fine.
Well, the point is, when you look at it, the people at the bottom might be working harder than the president. So they should actually be getting more care.
It's not about those that don't work at all, which is the reality of our country.
It don't matter. You see, what I always tell people is my outlook in life is that I'm happy that I'm the one who can work. And I'm happy to be the one who can assist. I don't want to be the one begging. And I feel honored and privileged to assist.
True.
If you want to swap and be the one that begs and you think people love begging, you're mistaken. What the people are looking for is opportunity. But what they are being treated, they're being treated as beggars. They're being denied opportunities so that others can feel better than them. What you need to create in this country is a safety net. What you need to create in this country is opportunity. What you need to create in this country is for people to understand that when we give you a grant, it's a temporizing measure. But what we owe you is an opportunity. To give you an opportunity so that you could be employed. What all of us deserve is human dignity. All those people that think people at the bottom want to beg, I've never found anyone that doesn't want to get out of that situation, that doesn't want to work. Maybe I haven't been there long enough, but I haven't heard of somebody that died from suicide because they were tired of begging. But I've had people that have died from suicide because they couldn't get a job, because they could no longer feed their children.
I hear you.
Now, for anybody to suggest that people want to sponge off others, they don't really know what the human spirit is about. And they've never been in that position, because the one thing that everybody wants is to be treated with dignity and not to be dependent on others, to make a contribution, to help others, rather than to be the dependent that is sponging off others.
You've said it. I have nothing else to say after that. I say, South Africans, your country, you make it what you want. It's all in your hands. And these are not even my words. Thank you very much, Dr. Letlape.
We just have to wake up, take the responsibility, stop being victims, and put our shoulders to the wheel.
Yeah.
And contribute.
No one is going to save us.
Nobody's going to save us.
Yeah.
Nobody's going to save us. I mean, one of the famous words of the JF Kennedy, in his famous speech around ask not what your country can do for you,
but what you can do for your country.
But what you can do for your country. One of the things that he says in that speech is the fact that we must remember in this world, God's work will surely be our own. God works through human beings. God doesn't come here himself
and say
to do things. You know, when you've been blessed, it's when somebody has done something for you.
That's true. That's always the case. That's how it works.
So God's work is what we do. So all those that are waiting for God to come to them, they are a burden on society.
They said he's going to come. They said Jesus is coming.
A burden on society. Remember, it's not long ago when I was a teenager. And what was encouraged was for people to work. Singapore was a poor island, but it said there will be no welfare. Everybody will work.
China was a poor part of the world. Look at it now.
So what we don't need is a welfare state. But that does not mean you do not assist people that are struggling. Everyone needs a helping hand.
Yeah.
But what you're doing, you help them so that they can rise too.
It seems difficult here in South Africa. But let's hope for a better future. Let's really hope for change. And you're saying that change is going to come from us.
Oh, it's going to come from us. And I mean, it's South Africans need to remember that as a human being, you only have one stomach, you know, and stop being greedy and stop stealing. and we just need to share. But we shouldn't forget where we come from. Yeah. And remember, we are the majority. And this is a trading world, and we should not be affirmed. What we should be looking for is to be given opportunities. Not grants, not 25% of a white man's business. I don't want it.
Not 350.
I want the opportunity to be able
to create my own.
And to serve society. We just need opportunity. We don't need handouts.
Yeah. There's a lot to take from this recording. It was meant to be about national health insurance. However, it became about the lives of South Africans and the challenges we face. And for that, I say, thank you so much. Thanks for your time. It's your work has been around. We've seen your work around for many years. You are and I'll use this, and I know you're going to correct me. You're quite a political player in the medical space. You'll probably correct me, and I'll take the correction.
No. I've always told people that I've been in medical politics for most of my life.
Well, there you go.
But my politics were not partisan. No. They're about saving society.
Yeah.
But I've been in politics. I've never deluded myself. When I engage in these issues, I know we engage on political matters.
And the objective is to serve the people.
Is to serve society.
Yeah.
It's not in pursuit of making one party powerful or the other. No, it's about society. The last thing that I want to share with people is that I travel a lot. And the one thing that I've come to adopt is an airline motto.
Okay, which is?
Which is, they tell you in an emergency. put a mask on yourself
And then
before you put it on
put on
others.
others. I know someone that says, I don't believe in that, but I hear you.
You know, so understand that matters don't help society.
Mm-mm.
I don't believe in dying for something.
Yeah. Put your
I
mask on
believe
yourself first.
in living for something.
Yeah.
That's all. Because when you're dead, you're dead. And the only contribution I can make is while I'm still alive.
So you put it first, and then you look for those that need help.
Yeah. Because if you got no mask on yourself,
You're going to
you're no
die.
use to others.
Yeah.
You're going to die.
Yeah.
You're going to die. And people need to remember that. We need each other.
Yeah.
But you must take care of yourself
That's true.
so that you can take care of others.
There's a phrase that says it's not easy to help others if you have nothing. So you have to empower yourself first, then you're able to help others.
You know, I don't totally agree
With this phrase.
with that phrase.
Correct us.
Because if you're alive, you have something.
Life.
You have life.
Mm.
You have wisdom. You know, you have things that you can share with others that are for free.
Mm.
You can greet somebody. You can smile at somebody.
Yeah.
Make their day. So yes, you can contribute from your humanity, from your values. Don't diminish yourself because you got no dime in your pocket.
Mm-hmm.
Because contributing to others is not about the dime in your pocket.
Yeah.
You can say something to somebody that changes their life.
Yeah.
Doesn't cost money.
Not at all.
It's just about knowing that all you're looking for is an opportunity, but you're prepared to work. And you don't look down upon yourself. You're a human being and you carry yourself with dignity. You know, when I traveled through Thailand, the people there are similar like us. There are lots of poor people. But there's one thing. They've retained their dignity.
Yeah.
It's when you lose your human dignity that you are on a slippery slope.
Are we at the
And human
risk of
dignity has
losing
got
it?
nothing to do with how much you worth or how much money you have in your pocket.
Are you at risk? Are we at risk of losing our human dignity as South Africans?
We've lost our humanity.
Okay.
That we've lost. And that's why when you come into this debate about NHI, everybody wants to protect themselves. The ones on medical aid wants to protect. Parliamentarians want to protect their medical aid.
Of course.
The others come with a scheme. But because it's not born out of love, it's not born out of how we're going to share. That's why they're not opening up. Sometimes someone has to be told, you got too much, we're bringing it back so that we can share. And you know, the best parable that I liked in the Bible was the one of, I think it's 5 loaves and 2 fish.
That's one. Yes.
Okay, that fed multitudes. And I came to understand that 5 loaves and 2 fish can't feed multitudes. The only way it can feed multitudes is when they embrace the concept of sharing. Not, is it enough? No, you need 2 grams, you need 5 grams. Sharing. Ka Setswana ba re, bana ba motho ba kgaoganya tlhogo ya tsie. And that's what happens in that parable. So when you prepare to share, there will be enough for everyone.
And losing humanity at its core is losing that ability
to share. And that's what we have when Maburu created medical aid, and we have blacks like me that are protecting it because we've lost our ability to share. Ha ke embrace bana ba ko gae, my poor cousins. Ke bona o kare ke tlo boela ko bone because I'm afraid. You know, but babantsho re na le this fear of poverty.
Understandably, though. We understand.
Well,
if you've tasted it, you don't want to go back to it.
No. If you make it your God, you don't want to go back there. So when you've tasted it, but it's not your God, you don't worry about losing it. Because, you know, my mom taught me something. Said the thing that you should look for, my son, is if you are healthy and you can work and put food on the table, be grateful.
Yeah.
It's not about if you have money, be grateful. No. If you can work,
if you can make a
honest
contribution,
living comes from my grandmother.
Yeah.
And that's what we've lost. And the fear of losing money, it's because you've developed an intense love for money. So for you, it's about money. It's not about opportunity. It's about money.
Wow.
Opportunities may come and go. Don't lose your humanity.
Yeah. Wow. It's been a lesson on life. Thank you very much, Re. Ke a leboga.
No, go leboga.
Wow, man. I truly appreciate the time you've given us. Kidi holiday nyana, so I'm glad you're able to come out. I see you're still working, it seems.
No, unfortunately, my career was short-circuited by some technical issues and issues of principle. I've been an ophthalmologist in private practice all my life. I went into private practice February 1989.
Wow.
And 2020, middle of COVID, my hospital group that I've worked with for more than 30 years said, if I don't have malpractice insurance, I can't go back. Now, in all these years of private practice,
Yes.
on principle, I will not take malpractice insurance.
What does malpractice insurance mean?
What's insurance or habaka husua? Insurance is sharp.
But why is that a complicated thing for you to take?
No, it's not. It's a matter of principle. I have no intention of malpracticing. It's like, I always give an example that, well, I don't have insurance for drunk driving because I don't intend,
you don't intend to
drive drunk.
Yes.
I don't have insurance for malpractice because I don't intend to malpractice. Malpractice is by intent. And if you go to court and you are being charged with malpractice, the court will be looking for whether you malpracticed.
Exactly.
Unfavorable outcomes is not malpractice.
No.
As long as I practice ethically, I don't need to insure for malpractice. I'll never do an operation that's not indicated. I'll never do an operation I'm not capable of.
But aren't you cutting your nose to
I will
spite
never
your
do
face then?
anything without consent. No. There are principles that I hold dear.
Yeah.
And it's not about money. It's about the values that I have. I've put a lot of things. What am I risking? I'm risking what? Finances?
Yeah, I'm about to say that it's not about money, but we need money to live.
Yes. But I need principles to guide me. If I lose my guiding principles and I'm in for money, then I can't find fault with the governments that we've had for the last 30 years.
You're in to survive as a human. We are the only creature on this planet that pays to be here.
The point is, my primary way of feeding myself has been through the practice of medicine.
Yes.
Okay. But I'm not going to do wrong things to feed myself. Because you see, what people don't realize is that once you get to that, you get to the point where you are an official and you are being forced to do wrong things, because if you do the right thing, you're out of a job. How are you going to feed the people? It's the same thing. It's the same principle. And I respect people that have said, I'd rather be out of a job than be forced to do the wrong thing. Okay. Whistleblowers. You are now saying people that are whistleblowing on things that are wrong and get killed for it should not do it.
I'm not saying that. I'm saying whistleblowers, according to the law, they should be protected. So there's a system that's supposed to protect them, and it doesn't.
But the point is, when you whistleblow in this country, you're taking a risk of being killed.
Yes.
You're not going to be protected because you're whistleblowing on the people that are supposed to protect you.
Well,
so how are you going to protect it? I'm just saying.
I hear the argument.
People have to understand that you got to have principles that you will not forsake for anything. And I mean, I can go to another country and they'll be happy to have the skill and I work there, but I'm not going to compromise my principles. Because you see, by paying malpractice, you are creating a malpractice industry. Lawyers, unscrupulous patients, and you are encouraging doctors to not practice ethically because they're insured.
True.
I'm saying, don't go there. Don't go there. That's you are violating something that is a guiding thing in my life. I walk.
Wow. That's a bold move.
I walk.
And you're fine.
I'll find other ways to earn a living.
That's why I'm asking. Maybe
There are other things I can do. I can start. People make money talking rubbish on other things. I can consult. I can do other things.
Yeah.
But my core and what I'm trained for is being an
medicine.
ophthalmologist.
Yes.
It's not like stopping is not without consequences. It has consequences.
Of course.
But I'll pay that price.
But don't you then lose something that's dear to you, which is practicing medicine?
When you have principles that you have to uphold, you're going to lose something that's dear to you. That's basically what it means.
Yeah.
I mean, if it wasn't dear to you, there were no principles around that issue.
I guess.
And there's nothing to lose.
And you're fine losing it.
Huh?
You're fine losing this thing that's dear to you.
I'm fine upholding my principles.
I hear that. And I knew that was the answer.
That's what I'm fine about.
Yeah.
The others, I will survive. Now, like I said, I'm still healthy. I can still work. And my mom taught me that's all that you need.
Make a contribution.
What you don't need is to compromise your values.
Wow, we learned so much today.
What you don't need is to compromise your values.
Yeah.
I'm still healthy. I'm still creative. I can still go out there and earn a living some way. I still have a responsibility to put food on the table.
That's
and I will
true.
find my way around without breaking the law.
Thank you very much. Wow. Lesson, life, principles. Hey.
King David Studio Podcast.